All right. Hi guys. Finally, everyone's in year 2 now. Congrats. So yeah, we're just gonna go through some basics this one session. We're not gonna take too long, probably just next 1 hour. And we're just gonna tell you like what's year 2 gonna be like and some clinical applications for your anatomy and physiology. And if you have any questions, just like pop it up in the chat and we'll just respond to it anytime. So yeah, so let's just start off with our intro to year 2. So like what's year 2 all about, So before we even start, I just realized that we actually had a lot of structural changes to PS Finger that I'm not sure if all of you are aware of. So for this year onwards, Peter and David won't be free anymore to join us. So it'll be Heini, me, and Ernest taking over and covering most of the content for this year. And yeah, so everyone just say hi to Ernest. All right. So this year, since we have like less people handling all the scope, we won't be covering all the content like last year. Like last year, we really covered all the content. We went through HKS and everything like that, provided notes on that. We can definitely do that, but this year we just want to focus more on high yield stuff because I feel like as year 2s, you'll probably know how to study, and we can point out all the clinical stuff that you need to focus on, and we'll try to provide as many questions as we can. Yeah. We won't be covering most of these and assignment stuff, but like if you want us to go through at any point in time during the semester or like provide notes, we can definitely try our best to do so. Yeah. So what's year 2 about? Unless you want to talk about year 2.
I think you can just do it. It's all right.
All right. So, I mean, I'm sure all of you have seen this like roadmap a couple of weeks ago that Richard has posted out. It looks kind of scary. You've got so many assignments to do, and you probably have your rural health placements as well. But we kind of simplified it even further. So we broke it down into assessments in Med 200. And this is basically a pass and fail module. You just have to clear it as much as possible. So you just have 4 assignments to do, 2 in Sem 1, 2 in Sem 2. And yeah, each of them is 25% each. Okay, so the best thing about this is literally it's pass fail module. So the other one, the Med 200, the scary one, the one which is actually graded. Again, it's broken down to four components. So your end of semester examinations, you have 4 of them, 2 in Sem 1, 2 in Sem 2, and each of them is 12.5%. And you have your online quiz at the end of each semester, which is 2.5%. And you've this year, Monash is going to include your OSCEs and VIAs. So OSCEs is a bit scary. It's because I'm sure you all haven't had a proper experience on it before, but hopefully over the semester you'll start to understand what can be tested, what can't be tested for OSCEs. And similarly for VIAs, it's 15%. So I mean, luckily for us, we didn't have to do VIAs, but I feel from advice from seniors actually that VIAs isn't that bad, isn't too scary, because as long as you can just touch up on your year 1 content from time to time, or even like do a PSP like what we're doing, you can definitely do okay for VIAs as well. Yeah, it's all linked to your year 1 and year 2 stuff. Yeah. Cool. So anyone else want to add anything else for that?
Did anyone have any questions about year 2? Because I know that like a lot of the information is going to be a lot like up in the air at the moment, and especially with VIA, since unfortunately we can't give you kind of like personal experience and kind of like information about that. But did anyone have any questions, like burning, stressful questions that they're like worried about in year 2? You can just type it in the chat if you want to. No? Okay, cool. Yeah, feel free to type any, just send any questions through if you have them. And yeah, I'll be popping in and out, but I'll leave it to the rest to take you guys through.
All right. Okay. So today we're going to keep it quite short, and every session we're aiming to keep it at least to maximum 1 hour, because I know everyone's going to be really busy with year 2 content. It's going to be a really hectic year, and so we just want to focus and highlight those key components that we found difficult that we when we were learning it last year, and we want to like break it down and explain it to you better, so hopefully it makes a lot more sense to you. So today we'll be covering clinical anatomy, key aspects of anatomy, as well as physiology. So yeah, so I'll go first with some clinical anatomy. So I'm not sure whether you've covered much for this first week of school, but I'll assume that you have covered a bit of your respiratory system. So how this year works is similar to how you studied cardio last year. It's by system. So you'll be studying respiratory followed by other systems throughout the semester. So within each system, you've got your anatomy, biochemistry, pharmacology, physiology, and whatnot. And we'll try to focus on the key aspects. So there are certain things like microbiology, pharmacology, where it's not too much, like we don't need to explain it. It's more of like memory work. And we'll try to provide you with tables where you can actually just read off and study from those tables instead of explaining those points again and again. Yeah. So starting with anatomy, for the respiratory, I'm just going to focus on key components of your respiratory system. So starting off with your bronchi. So in your before you go down to your lungs, you've got your windpipe, which splits up to your bronchi. So I'm sure you've covered this in your anatomy tutorials, but there's the bronchi of both your left and right are quite different, and this has really significant clinical features. So your right bronchus is shorter, wider, and vertical. So what does this mean? So this means that if there's any food that passes down your windpipe, it's going to more likely enter into your right bronchus because it's shorter, wider, and it's easier for the food to flow down there. So this is what's known as aspiration pneumonia. So if you notice here in this red circle, it's actually like something which has been stuck there, like food particles which has gone down the wrong tube. Instead of going down your esophagus, it goes down to your through your windpipe, through your right bronchus, and you'll see consolidation over here. Okay. So where will aspirated food go down to? So it really depends on whether the person is standing, lying down, and whatnot. So imagine the person's actually standing, your food will actually go down to all the way to the bottom. So it'll go down to your right side, your right lobe of your lung, and it'll go down to your posterior basal segment, which basically means the lowest part of your right lung. Okay. And if the patient is actually supine, so if the patient's lying down, it's not likely to go down all the way, but it's going to go down somewhere in the middle. So it'll go down to your right inferior lobe, the lowest lobe, but the superior segment instead. And if the patient's lying on the right side, so usually when we examine patients, we'll ask the patient to lie on their right. So if that happens, the food will end up going to the posterior segment of the right upper lobe. Okay, so these are a few key differences that Monash likes to test on, especially depending on the patient's position. Yep. Okay, so moving on. So that was your bronchi. So moving on to your lung. So in your lungs, you've got these things called your lung hilum, right? So what are your lung hilum? So they're basically a passageway for your vessels to pass through in and out of your lungs. Okay, so in your lung hilum, they're actually again different for your right side and your left side. So there's this key mnemonic. Right hilum, the anterior, and left hilum, the superior. So what's this referring to? This is referring to your pulmonary artery. So if you look here, your pulmonary artery of your left is superior to your bronchus. It's basically right on top of it. Whereas for your right, it's anterior. So your bronchus is over here, and it's anterior to it. Yeah. Oh, sorry, I missed one slide. Yeah, so let me just try to annotate. Okay, cool. So if you look here, this is your left and right, right? So you need to figure out which is your pulmonary arteries, veins, and bronchus. So the confusing thing is that this blue thing is actually your artery, and this is your vein, because you need to know that pulmonary arteries and veins do the exact opposite of what veins and arteries usually do. So your pulmonary arteries, they carry blood away from the heart, and pulmonary veins carry blood towards the heart. Pulmonary veins carry blood towards the heart. So, but pulmonary veins have oxygenated blood, and pulmonary arteries have deoxygenated blood. So that's why it's blue. Okay, and this is the bronchus. This is bronchus, and the same thing over here. Okay. So again, for both your hilums, the posterior structure is always going to be your bronchus, and what's different is your veins and arteries. So for your right hilum, your veins are going to be inferior, whereas for your left, anterior, inferior, and for the arteries, it's superior for left and interior for right. That's why there's this key mnemonic. Plurals, just right is anterior, left is superior. And just remember, this is for arteries in comparison to the bronchus. They like to swap it around, and they like to ask, bronchus in comparison to pulmonary arteries, and it's just opposite. Yeah. All right. So, what is the pleura? So, I'm sure you've had your Lazarus lectures so far covering the pleura, and I think she does a good job of covering what it is. Embryology matters, right? So the pleura is basically this layer of simple squamous cells, and it's like a sheet. Okay, you've got your visceral pleura, your parietal pleura. The same thing as like what you learned for your cardio. It's two layers that wrap around the lungs, and they form back onto the hilum. So they form a loop around the hilum. Okay, that's how you have an entry point for all the vessels. Okay, so the most important thing about this pleura is that there is potential space between your visceral and your parietal pleura. So usually there's fluid in between, which allows for lungs to expand, and which is good for inspiration, which we cover later during physiology. But there's a chance for this fluid to actually build up, and that's like an issue that leads to pleural effusion, which we'll cover later. So another key component about this pleura is that this pleura extends further. The parietal pleura extends further than the visceral pleura. So the visceral pleura wraps around your lungs, whereas your parietal pleura extends. So you need to know this key surface landmarks on your lungs. So it's a rule of two. So if you look at this diagram, the have a explanation here. So your lungs basically extend to T6, T8, and T10. Okay. This is how to explain this. Sorry, mid-clavicular line, mid-axillary line, and mid-sternal line, right? So mid-scapular line, sorry. And so this is posterior. This is to your side view, right? Your side view as well as your front view. Okay. And so your lungs is basically a rule of two. So your lungs extend 6, 8, 10, and your parietal pleura just have to add 2 to it. So your pleura at your mid-clavicular line will extend to 8. For axillary, will extend to 10, and for the back will extend to 12. Okay, that's basically a key thing that, again, monash flexors has. So since your pleura extends beyond your lungs, there's, again, this potential space for fluid to build up. So there is your costodiaphragmatic recess, as well as the costomediastinal recess. Okay, so looking at this picture, okay, so here is your recess. This is a space for fluid to build up, as well as here. I'll take it over here, as well as over here. Okay, so fluid can build up here, here, or here again. So both sides have costodiaphragmatic recess, as well as on your left side, because of the cardiac notch, there's a side of costomediastinal recess. Okay, so there's just important points for where fluid can build up. Okay, so when there's too much fluid, it builds up over in this area. This causes the angle, like basically means this angle gets be filled up with fluid, and so it's no longer as sharp when seen on X-ray. Okay. So this is what happens when there's a pleural effusion. So you'll notice that your costophrenic angle, like over here, there is blunted. You can't, it's not clear anymore. Okay, so this is a key component of like pleural effusion when there's a buildup of fluid in your pleural space. So between your visceral and parietal pleura. And so what happens is that it causes shortness of breath because it's difficult. It's when there's too much fluid, it's harder for your lungs to expand during inspiration and expiration. And because of this fluid buildup, it causes an irritation to the pleura, and this causes a pleuritic chest pain. So whenever you inspire, your pleura will rub, and this causes a pain. And a key component on how you diagnose pleural effusion is through chest X-ray, and you'll notice the blunting of your costophrenic angle. Okay. So that's a key thing that you need to learn for pleural effusion, the blunting of costophrenic angle. Yeah. All right. So moving on to diaphragm, I think you all should have learned this for the cardio. So this is just a simple recap of your diaphragm. So you've got your 3 hiatus. So you've got your aortic hiatus, T12, just your aorta, esophageal hiatus for T10, and caval opening, T8. And you just have to remember what passes through each one of them. So for your aorta, aortic hiatus, again, straightforward, it's just aorta. For your esophageal hiatus, you need to remember esophagus, your vagal trunks, as well as your left gastric vessel. And for your caval opening, it's your IVC, as well as your inferior vena cava, as well as your right phrenic nerve. So it's very important to remember which opening the right phrenic nerve passes through, as well as which opening the vagal trunk passes through. Because again, monash flexor tested. Yeah. So that's, again, a short introduction into clinical anatomy. And so now we'll be moving on to Physiology, which Ernest will be taking over from now.
Thanks a lot, RJ. I'll just be sharing my screen. Okay, can you see my screen? All right. Okay. Can you hear me, RJ?
Yeah, all good.
Okay, great. Okay, thanks a lot, RJ. So maybe I'll just start by introducing myself. Hi everyone, my name is Ernest, and third year medical student as well, together with RJ, Heini, and Jiting. And the four of us will be helping with PS Bingo this year. I'm really excited to be here, and we have a lot of like high yield content for you this year. So if you have any questions at all, or any feedback that you'd like to give, you can always message me on Facebook as well. Yep. And okay, let's get this party started. So I'll be covering respiratory physiology for today. And really, I find that respiratory physiology can get a bit daunting because there's like a lot of things going on at one time. But really, it's quite simple. I like to split it into 4 parts. So the chest, the airways, the alveoli, as well as the body. And today I'll just be covering the chest and the airways components of respiratory physiology. Okay, so really I'm just trying to paint a framework for you to fill in the details later in your own time through lectures or other resources that you have. So the first part on the chest, we'll be covering breathing mechanics. And in particular, there'll be 2 parts to it. One will be the whole mechanism behind tidal breathing and how Boyles Law actually ties in with tidal breathing. So, okay, start off with some definitions. So over here, let me just take out my cursor. So you can see over here, okay. So there are a few pressures that I'll want you to know about and that Monash actually expects you to know of. So the first will be the intrapulmonary pressure over here, which is actually equals to the atmospheric pressure, which makes sense because when you breathe in air, eventually enters your lungs. So the intrapulmonary pressure will be the same. And this pressure is actually 760. So I just write 760 over here and over here. Okay. Now, the key thing to note is that there's this thing called intrapleural pressure as well, which means within the pleura. And it's actually 756 millimeters per mercury. And the reason for that is because you want to create this negative pressure. So this negative pressure, we call it the transpulmonary pressure, trans being crossing and pulmonary being between like the lungs and the pleura. So this is actually 4 millimeters of mercury and it's actually a negative value. So what's the point of having this negative value? Is because the chest wall has this tendency to move out in this relaxed state. While on the other hand, you will want the lungs to move together with this chest wall. So in order for the lungs to move with this chest wall, you need some kind of suction force, a bit like a vacuum cleaner. And this will help to coordinate the movement of the chest wall and the lungs. And therefore you have this negative for transpulmonary pressure. Okay, next. Okay. Oh, shucks. Do I have to erase it every time? Okay, fine. Okay, so now this thing called Boyles Law. So Boyles Law, I'm pretty sure some of you have covered it in physics back in the day. So the thing about Boyles Law is that it says that P1 V1 is equals to P2 V2. Therefore, if you imagine if P1 actually decreases, then in order to equilibrate the whole equation, the volume will actually move from V2 to V1. So in other words, the air actually flows from a place of higher pressure, i.e. P2, to an area of lower pressure, i.e. P1. And that can really tie in very nicely to this breathing mechanics. So I'll just be going through the whole process briefly. So during inhalation, there's actually the contraction of your chest wall and your diaphragm as well. So your diaphragm moves downwards and your chest wall moves outwards. And because of that, the alveoli are actually pulled to expand. And the mechanism that it goes through is this, because if you expand the cavity, the thoracic cavity, the pressure within the thorax actually decreases in relation to the outside atmosphere. And because of that, air actually flows in from an area of higher pressure to an area of lower pressure in order to equilibrate the Boyles Law. So that will cause air to move in until P2 is equals to P1. On the flip side, if we have expiration, so usually exhalation occurs with a recoil of the chest wall. So it's a very passive process, but of course you can force it out by really like using your accessory muscles and such. But the broad concept is that the thoracic cavity actually decreases in size. This causes pressure within the cavity to increase in relation to the atmospheric pressure outside, and therefore air will flow out from an area of higher pressure to an area of lower pressure. And that explains exhalation. All right. So something to take note of is this. So this actually came up for Monash exams. Lungs actually expand and contract according to changes too. So there are two pressures that they change according to. One is the intrapulmonary pressure, and the other is the intrapleural pressure, which I explained before. It's essentially the pressure inside your lungs and the pressure inside the pleural cavity that sucks the lungs to the chest wall. And alveoli can be kept open by the transmural pressure gradient. So what is the transmural pressure gradient? It's essentially alveolar pressure minus intrapleural pressure, which is also 4 millimeters of mercury, because alveolar pressure is equals to intrapulmonary pressure, right? The lungs is the alveoli. Then there's also this thing called a pulmonary surfactant action, which we'll go through in a later time. But essentially the alveoli has this thing called munocytes, which will come out in the exams, munocytes. Type 2 munocytes in particular actually produce this thing called surfactant, which like maintains the surface tension of the alveoli and prevents it from collapsing. So that is the clinical relevance of it. A clinical condition that could come out testing this concept is pneumothorax. So pneumothorax is basically air in the pleural cavity. And what happens is that because of that, the transpulmonary pressure of 4 millimeters of mercury is actually non-existent, because air has already come in to fill the space. So because of that, the chest wall and the lungs aren't able to move in synchrony. And because of that, you have problems breathing and you get shortness of breath. So that's the whole pathophysiology behind it. Okay, next. So the second part, which I'll be covering, is airways. And airways, really, I'm just going to cover two things. First would be the factors affecting airflow. And the second would be the tools that we use to measure airflow and the volume within the lungs as well. So let's just break it down. Factors affecting airflow, there are two in particular. One is lung compliance, and the second is airway resistance. So what does this mean? So the first factor on lung compliance, there are actually three parts to it. So the whole idea behind it is we first need to understand what compliance is. So how I like to think of it is compliance means that something is loose. So the looser something is, the more, the easier it is for it to expand and contract. So that's the whole idea of compliance. If something is more compliant, it means that it is able to expand and contract easily. And that's actually in direct contrast with elasticity, which means like the elastic force that like resists against your expansion and contraction, right? So if something has high compliance, I would say that something is of low elasticity. Likewise, conversely, if something has low elasticity, then it expands and contracts easily and therefore has high compliance. So how does this affect airflow? Essentially, if the different parts of your respiratory system is elastic, it means that it is less compliant, which means that you're unable to expand and contract your airways or your alveoli very easily, and because of that, it can affect the amount of air moving in and out of your lungs. Yeah, if you imagine like creating the pressure difference and all. So there are three parts to it. First would be the elasticity of the lungs. Second would be elasticity of the chest walls. And third would be the surface tension of the alveoli. So this can tie in very nicely with three conditions, which I would like to talk about. The first would be elasticity of the lungs interstitial fibrosis. So essentially, interstitial fibrosis means that there's a lot of collagen and fibrin within your lung parenchyma. And because of that, the lungs can't really expand and contract easily, and therefore your airflow is decreased. Secondly, for elasticity of chest walls, there's this thing called scoliosis, which essentially means a stiff chest wall. And because of that, your chest walls are unable to expand and contract, and therefore affecting airflow. And lastly, for surface tension of the alveoli, this is actually the major factor affecting lung compliance. And in cases of newborn respiratory distress syndrome, kids have this genetic abnormality where they don't have the pneumocytes that I talked about previously. Because of that, they can't produce surfactant, and the alveoli essentially can't maintain its shape and collapse. And because of that, it will affect the amount of air that can enter your lungs. So that is the whole idea of lung compliance affecting airflow. The second factor that I'll talk about is this thing called airway resistance. So there are actually two factors behind this. First would be the type of flow that goes through the airway, and second would be the radius of the airway itself. Now, breaking it down even further, the type of airflow can differ between a large airway and a small airway. A large airway usually has turbulent flow, which means that like basically air moves in many directions, and therefore you can think of it as being more resistant. As for laminar flow, it's actually the particles can only go through in a very like only in one direction, right, through a small hole. And because of that, the flow through smaller airways is actually better and there's less resistance. So that is one factor we have to consider. However, the majority of this airway resistance factor is influenced by radius. And the reason for that is because of this interesting guy's law. I'm not going to bother pronouncing the name. But essentially, if your radius is decreased by half, your resistance will increase by 16 times because it's to the power of 4. So therefore, you can imagine a slight change in the radius of your airways can really affect airway resistance as compared to the type of flow. So there are two factors affecting radius. One is the collective radius, which basically means the sum of all the radius of all the airways of that size. So for instance, bronchi are usually the larger airways. They have larger radius, but there's only like 2 major bronchi that you know of. So if you multiply it by 2, it's actually not a lot. But if you think of something like terminal bronchioles, it's actually, even though each airway is very small, but there are many, many bronchioles. So the collective radius of everything is actually pretty big, bigger than you expect. So the good thing is that you don't really need to know like you don't really need to calculate it by yourself because this guy actually calculated it for you. So all you need to know for exams is that the resistance of airflow is actually intermediate. It's actually like moderate at the start, and as it branches, it slowly increases in resistance in the medium-sized bronchi, and subsequently, when you reach the terminal bronchioles, it actually decreases to a minimum resistance, as you can see from this diagram over here. Yep. And the next thing is bronchomotor tone. So essentially, sympathetic and parasympathetic systems can affect the smooth muscles surrounding these airways and henceforth affect the size of the bronchioles. All right, so let's move on. So here are the tools that we use to evaluate airflow and volume. And there are three things that I'd like to talk about. So I'll run through them. The first would be this lung volume graph, which in Monash land is actually pretty high yield. So you got to learn this by heart. And yes, you need to know the 4 volumes and the 4 capacities. So how I like to remember this is it's pretty simple actually. The volumes all form, they all add up together to form the total amount of air in your lungs. So the inspiratory reserve volume, the tidal volume, the expiratory reserve volume, and the residual volume. They form up the entire volume of your lungs. And then the 4 capacities I need to know is the inspiratory capacity, functional reserve capacity, vital capacity, and total lung capacity, in which the most important ones to know is this thing, the vital capacity and the total lung capacity, which I'll explain later during the later parts of spirometry. Okay, so 2 extra things for this. So firstly is that the residual volume cannot be measured. And let me just explain why this is so. It's because imagine you're just breathing in, out, in, out, in, you take a deep breath, and then you exhale fully. There's always that little bit of air left within your airways and within your lungs. And why is that so? It's because essentially you need that bit of air to make sure your lung and your airways don't collapse. And because of that, there's this residual volume that you can't measure because it's not actually blown out into the spirometry. So yeah, so that's the first point I want to bring up, is that the residual volume cannot be measured. And the second thing I want to bring up is exercise. So exercise doesn't actually increase or decrease your total lung capacity, because your lung and your chest wall is the same. The only thing that changes is the tidal volume, where it becomes a higher amplitude and more frequently as well. So in summary, this will increase the amount of air that goes in and out of your body per unit time. So that's the 2 things that I'd like to bring up to you. Okay, next. So next thing is this idea of dead space, which was very confusing for me at the start. But essentially, there's this thing called anatomical dead space, which like I previously mentioned, when you breathe out fully, there's a little bit of air left within your trachea, which doesn't actually undergo respiration because there is no alveoli and hence no capillaries to do the diffusion of gases or whatnot. So this anatomical dead space is normal, it's physiological, and it comes from your nose and ends at your terminal bronchioles. As for non-functional dead space, this is the other dead space I'll be mentioning next week, but essentially, if say there are certain parts of the lungs that are not perfused, then you can consider that area as like a dead space, because the air in those alveoli don't actually undergo through gas exchange. So that's non-functional dead space for you. Okay, the second tool that we're talking about is this thing called spirometry airflow. So two things I need you to know. First is the forced vital capacity, which is the full volume of air which you can exhale with 1 breath, which if you look back at this, is actually the vital capacity over here. And the second is this thing called FEV1, which is the forced expiratory volume, the volume of air exhalable in 1 second. So if I breathe out, within the first second, how much air actually comes out. So what you need to know is that the ratio is about 70 to 80%, changes from source to source. And this airflow spirometry is used to diagnose obstructive diseases and restrictive lung diseases. So I'll just be covering what both of these mean. The restrictive lung disease means that it's very difficult for you to inhale. So you can sort of imagine, right? Your total lung capacity, which is the amount of air that you can inhale at the end, actually decreases because you can't, there's a problem with taking in air. So this TLC actually decreases. But on the other hand, your your FEV1, which is the amount of air that you can force out per second, it's actually the same or slightly decreased. And the reason for that is because, let's say I have a problem taking air, right? It doesn't really mean that I have a problem breathing out the air, right? It may be affected a bit because of the difference in pressure or whatnot, but most of the time it's equal. So because of that, your FEV slash FVC capacity, TLC can also be FVC, because FVC is the total amount of air that you breathe out in one breath. If you can't take in enough air, then you have less FVC, right? So your ratio is actually increased or the same. In Monash land, just say the same. As for the obstructive diseases, so what happens is that you have a difficulty exhaling. So your FEV1 is actually decreased because you can't exhale air quickly, but the total amount of air that you actually take in is actually still the same. So your FVC or your TLC is the same, and therefore overall your ratio decreases. So this is really handy because based on these results, you can determine whether it's a restrictive or obstructive lung disease, and it's very, really important. And I'll show you why. Because okay, you need to know the diseases that are restrictive and diseases that are obstructive. And Monash likes to test this a lot. So restrictive defect, let's run through again. Restrictive defect means you have a difficulty inhaling, right? Which could mean like fibrosis or scoliosis, which essentially means that your chest and your lungs are not really elastic, so you can't really take in air easily. Therefore, you have a difficulty inhaling, a restrictive defect. Similarly to severe obesity, it's just difficult taking air, and tuberculosis as well. So you need to know these diseases in bold. The second thing is on obstructive defects. For COPD and asthma, they're actually obstructive. So why is that so? Because in asthma, you actually have a narrowing of your airways. And because of that, it's difficult for you to blow through these narrow airways, and therefore it's obstructive. For COPD, it's really very interesting because even though your alveoli compliance increases, and the reason for that is because the walls are weak, and therefore they are more like loose, and therefore they can take in air more easily. So it's like a negative restrictive kind of defect. But then as a whole, the alveoli and the airways actually close because they are damaged. And same thing, narrow airways, and it's difficult for you to exhale. So in summary, need to know the diseases that cause restrictive and obstructive defects, and that COPD is an obstructive defect. Okay, and last thing that I will go through today is flow volume loops. So, all right, this diagram is really, really very confusing, but I'll try to explain it. Essentially, on this axis, you have the volume, and on this axis, you have the flow. So Monash can give you these kind of diagrams, and you need to understand what it means. So for instance, when you exhale, okay, like imagine the positive direction is like the spirometer. So it's actually like receiving your air, right? Oh my God, this is such a bad drawing. Okay. It's actually like receiving your air, right? So when you breathe out, it's actually the rate, the flow rate increases until it reaches a maximum peak. And then it decreases in flow rate slowly until the end of your expiration. And then the total volume of air that gets exhaled, i.e. your FVC, can be measured over here. And when you inspire, it actually goes in a negative direction of the spirometer. So it is a lot more spherical in a sense. And yeah, it will move back to zero. So how can Monash test you for these kind of diagrams? To put it very simply, I would like to draw your attention to this severe obstruction and severe restriction. Okay, sorry, I'll just go back. So if you have a restrictive lung defect, then what that means is that you essentially have a problem inhaling air, right? And you, as we can recall, the FVC is actually decreased. So what this means on the diagram is that the endpoint is less on the x-axis as compared to this, because this measures your FVC, right? So your restrictive lung defect will look like this. So overall, you can see that the gradients are more or less the same. The only thing that changes is that your FVC is decreased. And this will be your diagram in a restrictive kind of pathology. Well, the next thing I would like to share is the obstructive defect. So just change the color over here. In obstructive defect, your FEV actually decreases, but your FVC is about the same. So what that means is that you can't really hit this peak over here because the flow rate is lower, but your total FVC most of the time is about the same. So you'll still end at this end over here. So what this looks like on the diagram, it looks like this. So you don't really hit the peak. And then you have this thing called coving. So which essentially means a very like concave kind of shape. And you'll end up still at this FVC over here. Yep. So this is what an obstructive kind of defect would look like. And I know my drawing is really messy, but it's actually a lot clearer in the next diagram, which I will show you next. Right. So you can just go back and like look at this diagram and try to work it out in your head. Obstruction and restriction. All right. So I think that's more or less everything I got for you today. So we covered the chest and the airways, and we'll be covering alveoli in the body next. Okay, and if you have any questions, just drop them in the chat and we'll cover them. But if not, I think we'll just end the session over here. RJ, do you have anything to add?
Yeah, so does anyone else have any other questions? If not, we can end it for today. Yeah, definitely we'll put up the slides. Sorry about that, we'll definitely put it up soon. Yeah. Other than that, like, does anyone have any questions with any of the content we've covered today? If not, soon we'll put up the slides soon, and we'll let you know when we're going to have our session for next week as well. Yeah.
Okay.
Thanks for joining, guys.
Yep. See you all next week.